Just want to put your full screen up so it's waiting for till 8 o'clock. Okay, ready to go.
All right, perfect. Thank you. We'll start it.
Right at 8. Yep.
Exactly at 8 is the idea.
Yeah, it's usually when people start.
Okay.
All right.
I will do that. Thank you very much for your help.
You're welcome.
Am I unmuted now?
Yes, you are.
Perfect. Thank you. So good morning and welcome to Grand Rounds. A couple of months ago on the consult surface, we were seeing one of our usual consults for acute kidney injury and reviewing the likely causes of that injury, which included things like hypotension and sepsis. When we started talking about contrast as being a contributor, the medical student on the service asked what was an excellent question, which was, does contrast really cause acute kidney injury? And today's Grand Rounds was prompted by that question and is a bit of a deep dive into the answer. And I can't advance my screen. Here we go. So IV contrast has been utilized since the 1950s. And today we're talking about intravenous contrast, the kind of contrast that you give for CT scans and angiography, not talking about oral contrast and not talking about gadolinium that's used for MRIs. But contrast has been used since the 1950s, and the first case reports of acute kidney injury occurring as a consequence of that contrast administration was reported in that same decade. I have seen so many people that I am convinced developed acute kidney injury as part of the contrast. So if you tell me and likely other nephrologists that contrast doesn't cause acute kidney injury, we'll probably look at you and wonder what other interesting ideas you might have that I probably don't want to talk to you about. But one of the main things that I remember from my first couple of weeks of medical school was a professor who stood in front of our auditorium and said to us as a group, there are lots of things that we will tell you over the next 4 years that aren't true. About 50% of what we tell you isn't true. We just don't know which half it is. So I think it reminds us that we need to remain humble and aware of the possibility that things that we've always thought were true might indeed be part of that 50% of things that turn out not to be true over time. I'm going to talk about 3 things today. And I have the same somewhat unsatisfying answer to each of those questions. Talk about whether contrast does indeed cause acute kidney injury, whether people should be pre-treated to prevent that acute kidney injury, and whether people should undergo dialysis after getting IV contrast. Let's start initially about what the evidence is that suggests that contrast does cause acute kidney injury. Again, I've mentioned earlier that a lot of case reports have indicated that people who got contrast developed acute kidney injury. And after that happens time and time and time again, you begin to think there's an association between the two that might be causal. That was supported by a number of animal studies that have shown 2 different mechanisms of renal injury in response to contrast administration. One is intense renal vasoconstriction, and the other is the cytotoxic effects that contrast exerts on both tubular epithelial cells and also on vascular endothelial cells. Data is too vast for me to go over in detail, but I do want to look at one study. This study looked at the effect of contrast media on vasa recta, which you remember is the capillary network that surrounds the loop of Henle. In this study, they used both human and rat vasa recta and looked at their response to contrast administration. They used the isoosmolar contrast medium and used the concentration and duration of exposure to that medium that you would expect to see in someone undergoing a cardiac catheterization. So on the panel on the left, you see an endothelial monolayer from a rat interlobular artery, looking nice and having the cell body stretched out along the direction of arterial blood flow. On the center and the right is that endothelial monolayer after exposure to contrast. And certainly those endothelial cells don't look nearly as happy as they did before contrast exposure. On the bottom is an indication of change in vascular integrity. If you look at the solid line with buffer alone, the electrical resistance is fairly constant around 1500, but after contrast, excuse me, and after contrast exposure, the resistance markedly drops down in the contrast media solid dashed lines. The other thing that they looked at in the study was the response of these vessels in regards to vasoconstriction. So this is an isolated human vasorecta on panel A and B, C, and D. It shows you the vasoconstriction that you can see in response to different vasoactive substances. On the right panel, if you look at the open circles, you see that the size of the diameter stays constant through the study. But the solid circles you see after exposure to contrast, there's a decrease in luminal diameter by about 40 to 50%. Next slide's a little bit busy, but if you focus again on the open circles, this is vasorecta exposed to increasing concentrations of angiotensin II, and you see, as expected, that the vascular diameter falls significantly in response to angiotensin II. And then if you add to that contrast media, which is the solid circles, you see that the luminal diameter decreases by about 90%. And at that size, a red blood cell would be unable to traverse that vascular lumen. So you have to allow me a slight segue, and I promise it's only 2 slides, into a bit of renal physiology. One question is, in terms of that vasoconstriction, is why do we care? I mean, the kidney gets an enormous amount of blood supply. The kidney makes up less than 1% of your body weight, but gets 25% of your cardiac output. And you'd think with those ratios that the kidney would be so richly oxygenated that a little bit of vasoconstriction wouldn't cause any problems. But if you look at the anatomy of the nephron here and the vasorecta that supply it, we look at this primarily to talk about osmolality. We talk about how the osmolality decreases as the filtrate goes down into the inner medulla in the loop of Henle using the countercurrent mechanism. What I want to focus on here is what's happening in the vasorecta, that surrounding capillary network. In order to avoid washing out that osmolar gradient, the capillaries have to follow the nephron down into the medulla and then back out again. And osmolality is not the only thing that's changing along that circuit. Oxygen concentration in the vasorecta is markedly changing as well, as demonstrated in the panel on the right. So if you start in the cortex, the tissue oxygen concentration is great, it's around 100. But then, as you expect, as it goes down and more oxygen diffuses out of those capillaries to supply the needs of the surrounding tubular epithelial cells, you see the oxygen concentration drop. But that's not the only direction oxygen is moving. Oxygen is also diffusing into the ascending limbs of this vasorecta, so that you have this incredible loss of oxygen capacity as the vasorecta descend into the inner medulla. As a consequence of that, in the inner medulla, the tissue PO2 on a good day with everything being normal is only around 8 to 10. So it doesn't take much of a perturbation in oxygen supply for this area that's already on the edge of hypoxia to get into trouble. So what we've got in terms of our hypothesis about acute kidney injury occurring in response to contrast is vasoconstriction may play a big role, and a direct toxicity of the contrast medium to both vascular endothelial and tubular epithelial cells. This has been the accepted wisdom for many decades, that contrast based on human studies and animal studies causes acute kidney injury. And the first voice that sort of raised a question about that was in 1985, when this study that was published in the Archives of Internal Medicine came out and said, hey, wait a second. I looked at a couple hundred people who got contrast in a retrospective study, pulled a couple hundred people who didn't get contrast, and didn't see any difference in the amount of acute kidney injury between those who did and didn't get contrast. Even that looking at higher risk patients, there was no apparent increase in the risk of acute kidney injury in people who got contrast. Now, as with many things where someone steps forward to challenge the conventional wisdom, this study was resoundingly ignored for another couple of decades. And then in 2006, our radiology colleagues step into the question. Now, our radiology colleagues are highly motivated to give us the best answers. And you've all seen those radiology reports where the radiologists tell us they couldn't give us good information because we didn't give contrast. They like us giving contrast in many studies just because it allows them to read the study better and give us better information. So 2006, they do a literature review asking the question, does contrast really cause acute kidney injury? And what they found was that of all the published studies, only 2 had control groups. One of them was the study that I mentioned earlier that Kramer did in 1985. And the second was a study published in 1991 in the Medical Journal of Australia. And those were the only 2 studies that had control groups. And in both of those studies, the incidence of AKI was similar in patients given and not given contrast. If you fast forward another 7 years, like 2013, there's now an increase in the number of studies that try to ask this question. And they were able to do a systematic review and meta-analysis. And in that review, with more studies available, saw a similar incidence of acute kidney injury, dialysis, and death between those that didn't get contrast. This is the forest plot from that study. And you see on the top panel, if you compare the risk ratio of getting acute kidney injury, that the combination of all the studies, if anything, suggests that the contrast receiving patients were maybe just slightly less likely to get, although the confidence interval does cross unity there. Down below, the risk of dialysis and death was also the same in those who did and did not get IV contrast. So those were our radiology colleagues. The other people who are highly motivated to make quick diagnostic decisions are our colleagues in the emergency department. They like to get the best information they have the most quickly so that they can make disposition decisions on their patients. This was a single center retrospective cohort analysis where they looked at a propensity matched study where patients who got contrast were compared to those who either didn't get a contrast enhanced CT scan or patients who got no CT scans whatsoever. And what they found in that study was that the amount of acute kidney injury didn't differ. If you got contrast, your risk of acute kidney injury didn't seem to be any higher than those who didn't get any contrast. So if you look at that study overall, the rate of AKI was basically the same in all the groups. And they drilled down and looked at people with varying levels of kidney function and showed, somewhat surprisingly, that the amount of AKI didn't even increase as the GFR went down, with the exception of the people maybe on the unenhanced and no CT scale, where their rate of AKI was somewhat higher. This was interpreted as saying that contrast didn't cause any acute kidney injury, but one of the things that I noticed about this study, which is interesting, even though they were supposedly matched studies, is that the overall renal function in the people who got contrast seemed to be a bit better than those who did not get contrast. So 88% of the people who got contrast had a GFR of over 60, and only 1% had a GFR less than 30. And that was a little bit better renal function than you saw in the patients who were not given contrast. Another study from our colleagues in the emergency department looked at, again, a meta-analysis, polling 28 studies over 100,000 participants, and said again, CT, the contrast administration was not associated significantly with acute kidney injury, dialysis, or all-cause mortality. This is the forest plot from that study, which again, we're getting a larger and larger number of studies that are basically coming up with the same conclusion. The odds ratio of getting acute kidney injury after getting contrast does not seem to be increased when compared to populations of patients who were not given contrast. So radiologists think it doesn't matter. The emergency department folks don't think it matters. How about let's wander into the critical care patient population? This was another single center retrospective study looking at patients presenting with sepsis, over 4,000 visits. And what they found is that the incidence of acute kidney injury looked no higher in the patients who were given contrast versus those who were not. we look at that data a little bit, you see that overall CECT is the contrast-enhanced CT scan in the column on the left. 7% of the overall patients got acute kidney injury, 9% of people who got unenhanced CT, 9.7% who got no CT scans at all. If you look at, however, once again, the renal function in the people who got contrast versus those who didn't, you see the same thing we saw in the earlier study, which is that the people who got IV contrast tended to have better kidney function than the people who were in the unenhanced CT or no CT groups. Since we're particularly worried about those folks who have the lowest renal function, the people with GFRs less than 30 in particular, you see the odds ratio of AKI, like in the bottom column in the center of contrast versus non-contrast. What you see is the confidence intervals are extraordinarily high for that group of people, somewhere between 0.15 and 4, which I guess is the statistical equivalent of an emoji shrug. We don't really have a good idea on those folks based on probably the small numbers. So we've had the radiologists, the emergency medicine folks, critical care input, and now this data is even wandering into the nephrology literature. So this study looked at the entire national data set for 2009, like almost 6 million patients. And what they found when they compared the patients who did and did not get contrast was the risk of AKI was identical between the groups. If you controlled for demographic, ventilation, and comorbidities, the contrast administration appeared to be associated with a slightly lower risk of AKI. So their conclusion was that the risk of AKI related to contrast was almost certainly overestimated. One of the things that probably wasn't surprising in their study was that people who were sicker tended to be more likely to have acute kidney injury. So this was the combined comorbidity score in the column on the left. And what you see in the adjusted percentages of acute kidney injury in the center, that the higher your combined comorbidity score, the more likely you were to get acute kidney injury, whether you did or didn't get contrast. So that one hot suggestion is that the development of acute kidney injury that we see in people who apparently get acute kidney injury secondary to contrast is just an indication of their physiologic fragility. Another interesting thing in their study, they divided folks in terms of what their primary cause for hospitalization was. And you see in most of these up at the top, you see all subjects where the open circle, no, and yes, getting contrast are so on top of each other that you can't separate them. Or for all subjects, the risk of acute kidney injury was about 5%, whether you did or didn't get contrast. By contrast, if you look at the very bottom, people who are septic, the risk of acute kidney injury was much higher. But again, maybe around 33% of the people who didn't get contrast and 36% for people who did. One interesting sort of outlier in this group is the people with acute coronary syndrome, where the people who got contrast had a much lower risk. So the people who got contrast had a risk of acute kidney injury just over 5%, where people who did not had a risk that was several-fold higher than that, maybe somewhere between 15 and 20%. And that sort of outlines some of the confounding variables that might exist in this population. I mean, who doesn't get contrast exposure with acute coronary syndrome? Those are the people who might have an ongoing GI bleed or a recent hemorrhagic stroke or a cardiac cath from just a month or so ago that showed that there were no lesions amenable to intervention. So these may be very different populations that you're looking at. Alternatively, the most optimistic, you could say that the performance of a cardiac cath and intervention improved cardiac function to the point where people were less likely to have acute kidney injury. So what we know so far is that the risk of acute kidney injury in response to contrast is modest at worst and almost certainly overestimated. In these studies, which are retrospective and observational, given the contrast was not associated with the risk of AKI, sicker people are more likely to get AKI whether they do or don't get contrast, but also People with a lower GFR seem to be less likely to get IV contrast. That's also not a surprise because that's the way most of us practice. So that messy data led to this sort of battle of ideas that was published in the Intensive Care Medicine Journal. And let's look at each of those different ideas. AKI is real, AKI is not real, or I don't really know. So the first, acute kidney injury is real. The argument is, come on, this stuff is toxic. We have tons of data that shows that in animal studies it causes vasoconstriction, tubular toxicity. The data that we're looking at in patients is messy. It's retrospective, it's observational. The patients in each group differ as much as you try to make them even. The prophylaxis differs. It is quite likely that there are residual confounders that we weren't able to control for adequately. One of the arguments they brought for that is this study that was published in JASN showing that the bottom line, the contrast was associated with a lower risk of developing AKI, to which their arguments was, if that's the case, you either have to believe that contrast is renoprotective, which is a bit of a stretch, or that there's a high likelihood of confounding by indication in the published studies, despite our best efforts to pick control populations that match the patients who got IV contrast. On the other side of that argument is the people who say it's a myth. And their argument is basically, how many studies do we have to give that say the same thing over and over and over again before we're going to start to believe our data? Each of the studies basically didn't see an increase in AKI in the people who got contrast. One example they brought up was two different studies. The risk of AKI after PCI was only 1 to 2%. But in a separate study, separate publication, the incidence of AKI after PCI for ST segment elevation MI was much higher, tenfold higher, 10 to 20%. The argument here was, if it's the contrast that's the troublemaker, the rates of acute kidney injury should be similar between the two groups. If the acute kidney injury is a function of how sick you are, then this result might not be surprising, since somebody having a PCI during an ST segment elevation MI is perfectly reasonably assumed to be sicker than somebody having an elective PCI. So their argument is, give up on your myth, believe the data, and move on. The middle ground is to say that this is messy data. Reported rates of acute kidney injury response to contrast vary so widely, somewhere between 1% and 30%. Admittedly, we've got meta-analysis that don't show any change in risk associated with contrast. And we've done our best possible propensity matching to reduce selection bias, and we still can't find an increased risk. And the other concern is that in animal models, if you just give contrast alone to a well-hydrated, healthy, happy, normal kidney function animal, you don't get acute kidney injury. You have to pre-expose that animal to either volume depletion or another nephrotoxin in order to see acute kidney injury. My argument here is, we don't give contrast to healthy people who are having a good day. We give contrast to sick people. And so the animal models that expose the animal to something else in addition to the contrast makes sense in the context of how we use contrast in clinical care. The conclusion of this middle ground, folks, are that the risk of contrast-induced acute kidney injury is probably not zero, but it's lower than we thought it was in the past. People who are frail might be at higher risk of getting acute kidney injury. Acute kidney injury typically happens in people who have other risk factors for AKI. And people who have a low GFR tend to be at higher risk of AKI, whether they do or don't get contrast. So where to go with all of this? How do I put this all together as a nephrologist? Well, I'm going to barge a little bit into pop culture. Hamilton's been playing cross country in living rooms everywhere since Disney Plus acquired it, I think, in July. So a little bit of Hamiltonian background for those of you who haven't watched it yet. One of the most prominent songs in Hamilton is The Room Where It Happened. The idea here is that Hamilton, Madison, and Jefferson, who are political foes, are at odds over some political issues. They get together, have a meeting, and come up with a compromise. But nobody really knows what happened, what compromises were made, what deals were made, what promises were made. All you know is the end result. And I think with AKI and contrast, you have the same scenario. Typically, we have several things in the room where it happened. There's kidneys and contrast and a bunch of other potentially bad players. What you know is that the kidneys emerged from this interaction beaten and battered, but you don't know who threw the first punch, who swung the bat, who kicked them when they were down. You don't know what happened. You just know the kidneys got injured. Occasionally, the room is less complicated. Occasionally, it appears that intravascular contrast administration is the only thing that happened. So contrast certainly looks guilty in that situation. But if you were the lawyer for contrast, you would argue this is all circumstantial evidence. And if you were contrast, maybe you could argue, hey, I just nudged the guy. He tripped, he fell, he hit his head. The fact that he's all banged up is not my fault. So what do you do with all this? I think you have two different possibilities maybe. One is to say, okay, I don't think contrast has caused acute kidney injury. I'm going to give it whenever an indication might exist. I'm not going to consider people who are thought to be at higher risk because I don't think this problem exists, and I'm not going to employ any preventive measures. That's one possibility. I don't necessarily think that's what the data suggests, though. I think what the literature suggests is that contrast doesn't appear to increase the risk of AKI the way we use it now. And the way we use it now is that we're cautious with administering contrast to people with lower GFR or people who we perceive to be at higher risk of AKI. And we employ preventive measures in those that we think are at a higher risk. And this is the strategy that I think makes the most sense still. So if we move to our second question, people should be pre-treated to prevent AKI due to contrast. So let me deal with the no part first. I think it's not necessary in people who are at very low risk for contrast-induced acute renal failure. So you would consider it in people who are at higher risk, maybe people with a lower GFR, people with other risk factors for AKI, or people getting a higher volume of contrast. There have been a lot of preventive measures that have come and gone, and those of you who are non-believers in contrast-causing AKI could argue quite rightly here, of course none of these things work. You're trying to prevent a disease that doesn't really exist, so nothing's going to be effective in that realm. I hear that point. The one recommendation that has stood the test of time is saline. Saline is basically our secret sauce for AKI prevention when the kidney is exposed to a number of different nephrotoxic agents. Amphotericin, aminoglycosides, myoglobin. If you give saline with those things, the risk of AKI is significantly less. And hypotonic fluids are less good at preventing AKI than isotonic saline is. These are the recommendations from the recent review on contrast and acute kidney injury that were published in the New England Journal last year. One recommendation is to use the lower osmolar or isoosmolar contrast agents. Early on, we were primarily using very high osmolality agents. Our radiology department routinely uses the low osmolar agents, may occasionally use the isoosmolar agents in those who have had acute kidney injury recently. So this is a given at our institution to use the lower risk contrast agents. Don't use more than you need, which is sort of an insulting recommendation, but avoid using large amounts over a short amount of time, avoid volume depletion or other nephrotoxins at the same time if you can, and to give IV saline. Obviously, this is not a great recommendation in somebody who has a contraindication for fluid administration. If you just diurese them out of their fluid or pulmonary edema, you don't want to put them back there by giving them saline before their cardiac cath. So that's the prevention mechanism, which are again, it's saline for higher risk patients. What about the next question? Should people undergo dialysis after getting IV contrast to get the dye out? The usual idea for getting the dye out is you're going to prevent AKI with that. So there have been 11 studies looking at that question with a total of 1,000 patients. And what they found was it doesn't help. It does not help. Here are those studies. And if you look on the panel on the left, you see this was challenging stuff to set up. The gray bar is the time of the contrast exposure. So there's one study where they actually started their renal replacement therapy before the procedure, 2 studies where they started it during the procedure, and the rest of the studies that started dialysis within 1 or 2 hours. If you think about logistically how challenging that could be, this is an impressive effort. What they found, if you go to the panel on the right, is that if you look at people with CKD stage 4 and 5, that's people with a GFR less than 30, that again, it didn't seem to make a difference. The risk ratio crosses unity, doesn't look like it helps. And if you look at just a couple of studies that looked at stage 3 CKD, again, those are people with a GFR of above 30, they, if anything, look like they did a little bit worse with dialysis. So should people undergo dialysis to get the contrast out afterwards? No. What about people on dialysis? What about people with end-stage renal disease? Well, if the idea of doing dialysis after contrast is you're going to preserve their residual kidney function, this study says it doesn't help. Otherwise, there's no need to dialyze after getting iodinated contrast. People can just go back and get dialyzed according to their regular schedule. So what's the yes part on this answer? Well, the yes part in here regards gadolinium. So I'm taking a side street here, talking not about iodinated contrast material. We're talking about contrast given for MRIs and MRAs. So back in the late 90s, we started to see this strange disease in people on dialysis. And it took several years to figure out what the trigger was. It was clearly a new disease, and it was clearly bad. These folks got really painful thickening of the skin in their legs and trunk. It looked very much like scleroderma, except that it spared the face. And it was, for the folks who got it, quite awful. What we realized afterwards, after people put it together, was the culprit for this was the gadolinium. So gadolinium is known to be toxic. It causes fibroblast proliferation. It causes collagen deposition. But it wasn't given as free gadolinium. The gadolinium was chelated with a carrier that was administered, and it was a low molecular weight carrier. So as soon as you gave it, it would be excreted through the kidneys. The problem was the studies that looked at safety and efficacy were done looking at people with good kidney function. Once MRI and MRA imaging became more widely used, we used a lot of this in people with end-stage renal disease because we were trying to avoid iodinated contrast. And so people would get high doses, multiple doses, and then we started seeing this problem. The challenge is that once this substance is retained in the body and not excreted, it's got no place to go. And the chelating agent is perfectly willing to give up the gadolinium in exchange for another cation, such as iron or calcium. So now you've got the chelate keeping calcium and iron off the streets, which you don't really care about, with free gadolinium in the tissues causing toxicity. So the story with gadolinium is the yes part of should you do dialysis after getting IV contrast. Do dialysis after getting gadolinium-based contrast agents immediately after, and then daily for a total of 3 treatments. The question has become, what do you do about people with chronic kidney disease? Well, there's only one reported case of nephrogenic systemic fibrosis in somebody with a GFR above 30, so that's not a worrisome group. The gray area has always been people who aren't on dialysis but have a GFR of less than 30. There was a nice study published this February in JAMA that was a systematic review and meta-analysis of patients who had gotten the newer gadolinium-based contrast agents. The old agents in group 1 were associated with a higher risk of NSF. The newer group 2 agents have a much lower incidence of nephrogenic systemic fibrosis, probably because they are less willing to exchange the gadolinium for other cations. And our institution uses Gadolinium-Based for our imaging studies, the group 2 agent. So if you look at these studies, what they found, 16 studies, almost 5,000 patients, the number of incidents of NSF was 0. Emphasize 0. They saw no NSF in these patients with gadolinium exposure who had a GFR of less than 30. I love a good title. The risk is 0 good enough. So that was the accompanying editorial to this article in JAMA. So their conclusion from this study was that we can be more permissive about using this group B gadolinium-based contrast agents in people with stage 4 and 5 CKD, because those are the group of people we were worried about. Now, the only caution is only 5 of these studies were prospective. The majority of them were retrospective studies. So one concern is the duration of follow-up and the number of patients who might have been lost to follow-up in those retrospective studies. So you are not quite as certain as you would like to be, but this is the best evidence that we have so far looking at gadolinium in people with more advanced chronic kidney disease. So the conclusion are, you can use this group 2 contrast agents, which is the one that our institution uses routinely, cautiously in high-risk patients, including those on dialysis. Again, don't give more than you need. Don't give it over and over and over again. And if they're on dialysis, do dialysis shortly after the exposure. And I would continue to do the daily for 3 days, just because I haven't seen NSF in many years, and I would be quite happy to never see it again. So let me go back to my 3 questions, my 3 issues here. Does IV contrast administration cause AKI? Yes, it's likely real. I think it is. I think there's enough animal data, enough human data that suggests it may be a causal agent of AKI. And no, it's not as bad as we thought it was in the past. The risk of AKI with a contrast seems to be low with our current cautions. Next, should you pre-treat people to prevent contrast-induced acute kidney injury? And again, yes and no. Yes, give saline as prophylaxis if there are no contraindications to doing that for people at increased risk of AKI, and no for people at lower risk. And then the last question, should people undergo dialysis after IV contrast? Yes, if they've gotten gadolinium and they are on dialysis, and absolutely not for iodinated contrast. Up to Date has this nice section of things that is called the practice changing update. I think I can call this presentation a practice not so much changing update. Because what I'm encouraging is, I think the data tells us that we should keep doing mostly what we've been doing. That we are cautious about giving contrast in people who have a higher risk of AKI, which seems to be appropriate because that's what was done in the studies that didn't show an increased incidence of AKI in people who got contrast. One of the worries always has been that we will deprive people who need diagnostically or therapeutically important procedures because we're afraid of contrast. And I think this data gives us more permission to think about what those benefits might be. Now, certainly I think it's still reasonable if somebody's at higher risk to think, are there other diagnostic or therapeutic options that exist to me that wouldn't involve giving contrast. The radiologists are great at talking with us about what our questions are and whether or not we really need to give contrast in order to answer that question. One thing that I think is perfectly reasonable is to update terminology. This used to be contrast-induced nephropathy. When the term AKI came out, we sort of transitioned to a contrast-induced acute kidney injury. I think the weight of the evidence says that it's pretty uncommon to be able to be confident that the contrast was the cause of the acute kidney injury. So maybe the more honest term is to say that it's contrast-associated AKI rather than contrast-induced. So I began with a view of the Ansel Adams Wilderness in California, and I leave you with a different view. This is from Dolly Sods in our own West Virginia. Thank you very much.